Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live with another legend, Professor Pazouki from Tehran. As you know, we have started this series of MGB OAGB with Professor Rutledge, and we will continue our series about MGB OAGB. And the end of this series will be with Professor Carbajo, another legend. So during this series, so every week we continue this series, and the main expert of MGB, OAGB from all over the world. They are participating in this series. At the end of this series, we will have again a sum up session. So, what is our target? We are trying our best to share the knowledge and experience of these legends. And in my opinion, this is a great opportunity, especially for you youngsters, to avail this opportunity and to hear the experience of these legends. I am grateful you have taken time, sir, to accommodate in MGB OAGB series. It is a great pleasure to be able to interview such a reputable figure. Everyone, I present to you one of the legend in bariatric surgery, Professor Pazouki. Professor Pazouki is from Tehran. He is also director of mini fellowship program of minimal invasive surgery. He has started this fellowship program since 13 years in Iran Medical University, and as well as now there are many other centers for training, especially in bariatric surgery and fellowship program. He also started this journey of bariatric surgery about 13 years ago, as well as with lot of experience in MGB. Sir, over to you, sir. Sir Pazuki, really appreciable, and I know you are so much busy. So, this for accommodating this time, it is great honor. Sir, you are live on Facebook, and thousands of bariatric surgeons are excited to hear from your side. Sir, please.
Hi to everybody. I'm glad to share with you my experiences. At first, I should thank Professor Omran Abbas from preparing such good educational programs, and I think he told everything about me. We started fellowship program from 13 years ago in Iran, and fortunately at present we have 6 university educating MIS fellowship program. Although in our country, Iran, there are many general surgeons who also doing obesity surgery. I started OAGB, MGB from 8 years ago, and among my patients, I have done 6,639 cases of bariatric surgery till now, and 3,219 cases of OAGB I've done during these 8 years. It means that 48.5% of my patients I've done for them OAGB, MGB. And it means the most of my cases were OAGB, and it's, in my opinion, a very good procedure. And I started at first with mostly Roux-en-Y gastric bypass. But when I started OAGB, I should note the recommendation of Professor Tacchino, who, when I went to Italy to his department. I saw that he's doing OAG. I asked him about OAGB, MGB. He told me it's a very good procedure and do it. So when I came back to Tehran, I started it in my and at that time no and we started in both university affiliated and also private hospital these operations. And after 1 year gradually some of complications was appeared, and I saw that some of these patients are nourished, and they have some complications about using this procedure. I was upset and I wanted to put it away, but our epidemiologist, Dr. Kabir, told me you should not by only a few cases put it away, and you should see the results of all the patients. And when we evaluated our patients at that time, we saw that most of them have a very good results, and even better than Roux-en-Y gastric bypass. And at that time, it was strange for me to use the same length of biliopancreatic limb for all the patients with different BMI and different age. And because one of our cases, one of my fellowship cases died after liver insufficiency, we reported it, Dr. Abdul Hosseini, and the second case, mortality also by one of staff, Professor Khalaj, and also we published these two cases. And after that, I saw Professor Karbacho in Dubai in the IFSU Congress and I think MESA Congress. And I told him that in my opinion, it's better to use less length of biliopancreatic limb for patients who have BMI less than 50 or their age are more than 50 years old. He told me the same results in his patients, and after that I adjusted my length of biliopancreatic limb for my patients. And after that decision, the results are very good and with very, very few major complication. And I think it would be a good procedure. And as you see in textbook of ASMBS for bariatric surgery, it was printed in that as a chapter in that edition, in the last edition of ASMBS textbook for bariatric and metabolic surgery. And I think in next few years, ASMBS also will accept it as a standard procedure, although if so, has accepted it as standard procedures from many years ago.
Sir, excellent information. So we will continue our discussion. So as you have mentioned earlier, so with this huge number of bariatric surgery, about 50% of your cases belong to OAGB. So definitely you see some benefits, and also you and your patients are happy. So sir, I will continue because we have some repeated question. So I will try my best to ask this question, because at the end, when we will have sum up session that day, so again we will also, because that day will be a long session and same question, but we will hear different opinions from different experts. Due to this, there are some questions that are repeated question. Sir, as you have mentioned, so earlier stages you had some issues, especially malnutrition and also some complication, and then you review your technique. So what is my question? So be definite you have reviewed your technique for your better results. So what was these key points? So just I will mention length of pouch. Have you increased length of pouch? And also earlier you have mentioned you decreased and you adjust your BP limb for the patient more than 50 years or BMI. So just I want to hear 3 points regarding your change of technique, regarding length of pouch. Have you increased length of pouch? Second one, the size of this gastrojejunostomy. Have you changed your size of this or place of this gastrojejunostomy, like anterior, like posterior, side to side? Sir, please, over to you.
Yes, really, everyone will change his technique after he has enough experience, and every time we are changing as our experiences increases. About the length of the pouch, yes. At first, we had shorter length of pouch, but at present, we start distal to crowfoots and incisura. And after applying the first stapler, we go along the lesser curve toward the his angle. And about the type of anastomosis, yes, at first we used 4.5 centimeter, but at present I do about 3 centimeter anastomosis for my gastrojejunostomy. And in my opinion and my experiences, I don't use anterior anastomosis because of I'm sure many of bariatric surgeons who are doing OAGB have done many times Roux-en-Y gastric bypass. In Roux-en-Y gastric bypass, you can use both anterior or posterior anastomosis for your gastrojejunostomy. But for OAGB, in my opinion, it should be done only posterior because of two reasons. I had a case that when I am in my early experiences, I used anterior as I used previously for Roux-en-Y gastric bypass. But unfortunately, my patients, if you do your anastomosis in the anterior of the gastric pouch, it will be rotated and like volvulus, the limb of small intestine will rotate the pouch, and the pouch will be prone to ischemia. It's the first, and I had a bad event for my patients, and because of late uh, coming to hospital, unfortunately, he came with profound peritonitis, and he was died, unfortunately. The second reason to use posterior anastomosis for gastrojejunostomy is because it will decrease the risk of bile gastritis and bile reflux from small intestine to stomach. Because when you are eating, you are in sitting position, and in this position, when you use posterior anastomosis, there will be a way for emptying the bile, even if it will when it's in the as a Novdan will be what the meaning of Novdan in
Yes, sir. Just yes. What is that flow of bile will be
yes,
restricted. Yeah, because we
yes,
need the
and
flow.
so we teach our fellowships to use posterior anastomosis, and this
Sir,
is one.
excellent. Sir, excellent, really. So, yes, because this is my honor. Now I am interview my mentor, Professor Pazouki is my mentor. And I remember those days about 6, 7 years ago, 8 years ago, when I was under supervision of Professor Pazouki, and every day I know his research, and also he was trying his best to do the best for the patient, definite. And so these techniques, definite, sir, as you have mentioned earlier. So every person, when he is going to do something, so he must change his technique according to the need of the patient and this experience, because overall bariatric surgery is a new baby. It will, and also in the evaluation period, and it will take time to mature these techniques overall, all of them. But one of this, one anastomosis is gastric bypass. Sir, another thing, another question regarding, so you know better than me. I remember at that time also 7, 8 years ago when we were together and also discuss about marginal ulcer and reflux and GERD. That was the main concern. I remember at that time, and I remember how much you have faced resistance, other bariatric surgeon, how they also criticize this. I remember this technique. So now we are in 2021. So there are a lot of changes of technique. So, sir, also you remember now, some months ago, Di Maria also mentioned this and highlight earlier cases of Rutledge in USA, and also this GERD about marginal ulcer and especially reflux. Sir, are you agreed now in this era, now 2021, OAGB is still this main concern is GERD and marginal ulcer, or no? What is your thinking about this?
In my patients, I have about 4% of GERD. And you know, as I have differentiated the types of reflux. At first, it may have bile gastritis in the patient, and it will, in my patients, about 4% had GERD esophagitis. But another thing is the risk of afferent loop syndrome, which the patient's complaint is when she's sleeping in the night, she will be awake by a reflux of large amount of very bad tasty liquid from his stomach back to his mouth, and the patients tell that many times this liquid goes even to his ears, and it's so much high amount of liquid. And it should be differentiated from gastritis, bile gastritis. This is afferent loop syndrome, which mostly occurs during the night when the patient is sleeping. And as, and by adding them to I had about 4% of my cases had GERD esophagitis or afferent loop syndrome. About the stomach ulcer, also I have about 4%, pardon me, about 1% of my patients have a stomach ulcer that mostly are treated by conservative and medical treatment, and only 3 patients among these 3,000 cases I did revision for stomach ulcer that was not treated by medical treatment, and it was resistance ulcer, and we changed the OAGB to Roux-en-Y gastric bypass and resecting the ulcer.
Sir, excellent. Really, very. Your interview is very with full of experience and also very informative. Sir, regarding this endoscopy before surgery and also H. pylori, is this your routine practice before surgery?
Yes, every time from my early experience, we made endoscopy as an obligation for all bariatric surgery, because and we think that it should be done when the we have more data about our patients, and when we use about the esophagus or hiatal hernia that are seen in about 30% of our cases, we prefer not to do sleep for them. Another important finding that during these recent years was added our knowledge about the problems that may occur in the future for the patient is biopsy from the stomach, and we do not only upper GI endoscopy, but we tell the endoscopic gastroenterologist to take biopsy, because sometimes we have intestinal metaplasia, and in this situation it's better to use for these patients a sleeve gastrectomy to reduce the risk of gastric cancer, and also have opportunity to have access to the remnant of a stomach which remains with the patient. So in our opinion, upper GI endoscopy is necessary, and in the consensus by IFSO, it was insisted that we should do it during these recent years.
Sir, excellent. So during in this experience, now you have a lot of experience. So you are routinely do endoscopy before surgery. How many percentage or how many cases you have changed your planning? So due to this intestinal metaplasia, or have you, or you remember? So you have planned MGB for the patient or Roux-en-Y gastric bypass. So because now we are talking about OAGB, but due to this endoscopy and result of biopsy, you have changed your planning, and also you changed to sleeve gastrectomy. Or you remember how many cases you have changed?
Mm, In these 3 years, we did biopsy for our patients, but at present I don't have a, definite statistic about the percent of patients, but we will in near future publish our results of gastric mapping and also esophageal distal esophageal mapping for patients before operation, and in near future our results will be published.
Excellent, sir. Sir, in also another question regarding H. pylori. So, are you eradicate H. pylori?
Yes, because you know in our country gastric cancer is a major problem, and so we eradicate all the H. pylori positive patients before the surgery.
Excellent, sir. Sir, another question regarding GERD. So, if have you experienced, are you prefer to do surgery in OAGB in a case with documented and also symptomatic GERD? Patient has symptom of GERD, and also your endoscopist also confirm this reflux. Have you experienced to do such a patient OAGB?
Uh, yes, I think I can tell you about the main comorbidities of my patients. Uh, Among my patients, as I told you, more than 3,000 cases, 94.7% of my patients who have done, I've done for them OAGB had different type of comorbidities. 22% they had diabetes, 11% had fasting blood glucose between 100 and 125. It means impaired fasting glucose was 11% and 22% they had diabetes type 2. 33.5% had dyslipidemia, 19.5% had hypothyroidism, and 22% also had hypertension, and 13% sleep apnea, and among them 15% had heartburn. And I did for these 15% also mini gastric bypass, and I had very good results in patients who had and as I told you, in 15% of my patients, it means
About
about
500 cases. About 500 cases.
about 484 cases, they had heartburn, and I've done for them OAGB.
Sir, excellent, really. And
The other comorbidities, 55% had low back pain, 57% had knee pain, 29% headache, 28% psychiatric problems, 0.5%, it means half percent had pseudotumor cerebri, and 18% menstrual abnormalities, and 17% had stress incontinency.
Sir, excellent. Really, I know because how you follow your patients at your center. That is the one of the organized center, and I remember how you this maintain your data. Sir, regarding this GERD, so what is my question now about 500 cases with heartburn? You did OAGB. So, have you one of any case worsen condition? That condition become worse. That symptoms or heartburn or reflux become worse. Are you remember any case?
And as I told you, about 4% of my patients had bile gastritis and bile reflux or afferent loop syndrome. But overall, I had very good results among my patients. And at present, I tell you that we are we are doing endoscopy, and we have searching among our patients after 2 years for sign, and for all of them we are doing as a research upper GI endoscopy, until now. I have done, I think, about uh, about more than 200 of my patients who are more than 2 years of OAGB. I have seen even one case or any distal esophagus from having esophageal cancer, as the document shows us, is very, very, very low, and we should not uh, mm, fear from that risk in OAGB.
So, as you sir have mentioned, so now in last 3 years, so this is your routine practice to do endoscopy after OAGB, especially for the patient after 2 years, and it is, in my opinion, this will be a great help for humanity because now as if you remember, so last week I was with Mohit Bhandari, and also now this is the routine practice of Mohit to do endoscopy after surgery. Also, he mentioned percentage of marginal ulcer. So, what is my question? So, during this about 200 plus that you did, I think, endoscopy for your patients, how much percentage was marginal ulcer? That was asymptomatic or symptomatic?
And about, I can tell you the as hospitalization,
Sir, your mic.
pardon, my statistics for hospitalization for late complication, I have 12 cases who were hospitalized for a stomal ulcer as late complication. And as I told you, only 3 cases of them I did operation and revisional surgery.
Sir, regarding this, sir, you have mentioned earlier, so you did surgery for some case that was intractable GERD or reflux, and you have changed to Roux-en-Y gastric bypass. So also some of surgeons they believe so we can do just brawn. And also, I remember at that time we have a series initial. If you remember, we so at that time so this mini gastric bypass with the same initial brawn. Have you completed that study, and what was the results?
And our results for Brown was not as good as Roux-en-Y gastric bypass. And even we had a case with severe bile gastritis that had a Brown anastomosis. And in my opinion, we had an RCT that between 70 cases of patients with and without Brown anastomosis. It means 35 cases had Brown and 35 cases didn't have Brown. And we saw that although the Brown decreases the rate of patients epigastric pain. You know, mostly the patients have epigastric pain as bile gastritis, and there was very low difference between these two groups. So we don't did Brown anastomosis after that survey that was done about 8 or 7 years ago, 7 years ago, because we started about 8 to 9 years ago, OAGB, and after 2 years, we had some cases of bile gastritis, and we evaluated Brown anastomosis to decrease this problem, but we saw that it was not so effective. So
Sir,
we don't do it anymore.
sir, another question. So you have mentioned also, so this size of gastrojejunostomy you have decreased. Why you have decreased? There was weight regain.
Yes, no, not for weight regain. To decrease the risk of bile gastritis, because it's rational that as the size of anastomosis more length make the patient more prone to reflux. But we haven't any RCT about it. It's only an opinion.
Okay, sir. Sir, regarding hiatal hernia, so in a case because you know better, so in morbid obese patients, routinely we can see hiatal hernia. Are you prefer to do surgery in such a case? And if you prefer, are you repair that hiatus hernia?
No, we don't do it. And even I had some cases of even large hiatal hernia, and I didn't, not only I didn't repair it, but I came laterally and I did the, I prepared my gastric pouch, and you know, when the anastomosis is done, it will make the hiatal hernia to be reduced into the abdomen. And even I had a giant hiatal hernia that was about half of the stomach and a part of omentum in the mediastinum, and was herniated to the mediastinal space. and I did for her mini gastric bypass, and recently she came to me and I did I asked her about any sign or symptoms of uh, GERD. I did. She hadn't any problem, and I also sent her for upper GI and barium swallow, and I saw that although there is a small hiatal hernia, sliding hiatal hernia, but the size of hernia was reduced, and it was, I think, it's a great success for not only Roux-en-Y gastric bypass to treat the patients with hiatal hernia, but also for OAGB we can use for hiatal hernia, and the patient will have benefit from these procedures uh, as in my experience.
Sir, excellent. It means so in future we can see one of the option of this hiatal hernia in morbid obese patient will be OAGB. Sir, excellent. So regarding sir this tailored BP limb, you have explained in initial surgery. So what is your opinion in redo surgery if a case after a sleeve gastrectomy and weight regain? So how you are you measure whole bowel and also this small intestine, all the length, and how much will be any criteria for this BP limb in such a case?
I should tell you at first about the my technique for choosing the length of biliopancreatic limb for the primary patients. The for at 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 this time, I mostly because one of our fellowships had a research to measure the length of a small bowel in the patients of morbid obese surgery. And Dr. Abdul Hosseini has measured in more than 700 cases, and he showed us that the most important things related to the length of the small bowel is the height of the patient. And he saw the patients had a small bowel between 2.55 centimeter to or 255 centimeter to more than 12 meter between the cases. But the most important factor was related to the length of the small intestine was the height of the patients. So at present, I use mostly for my patients their height as a major thing for decide how uh, how many centimeters of the biliopancreatic limb. When I have done, as you know, I've done many cases of Roux-en-Y gastric bypass, and till now I've done more than 1,546 cases of Roux-en-Y gastric bypass. And for these patients, when the BMI is 40, we use the summation of biliopancreatic and alimentary limb. When the patient BMI is 40, the summation of A and B limb is 170 centimeter. 170 centimeter. And when the BMI is 45, I use 185 centimeter, the summation of these A plus B limb. And when the BMI is 50, A plus B limb is 2 meter. For OAGB, I decreased 20 centimeter for these patients. It means when I have a patient with BMI 40, I use for him or her 150 centimeter length of biliopancreatic limb. And when the BMI is 50, I use 180 centimeter length of biliopancreatic limb. But when the patient's height is, for example, 160, and his or her BMI is 50, I don't use for her or him 180 centimeter. And because her height is 160, I decrease the length of biliopancreatic limb to 160. But about your question for the revision, it's my and it's my experience as published in ASMBS. It's the same, and I've done for sleeve, re-sleeve, and I've done for them sausage, and I've done for them changing to Roux-en-Y gastric bypass, and also changing and revision to OAGB. And the best results I had with OAGB. And about deciding the length of biliopancreatic limb in the revision, I asked the patient about his primary weight before doing a sleeve, and his or her BMI before doing a sleeve. And I do my decision according to that BMI. But as we know, the patients, when we do for him or her revisional surgery, has less chance of losing weight, and weight loss in revisional surgery is very fewer than the primary surgery.
Sir, I understand, and really, it's again very informative. So, from this your debate, I have some question, and one of my question is regarding this. So, because you must see in revisional surgery the BMI before surgery, just a scenario, a patient with 60 BMI, you did, or any person did standard sleeve gastrectomy. Patient lose weight and touch the ideal, and also lose all excess body weight. Now patient so return to you with BMI 45. Before surgery it was 60. Okay.
Yes.
And also touch 30, 33, 35. Yes. It and then now so patient was 35. Now again after 3 years, 4 years, now with 45. So what you will do in this case? How much will be BP limb?
And it's a good question, and I should complete my answer about the previous question. When the patient's BMI is between 40 to 50, it's easy to measure the length, total length of a small bowel. And in these situations, we prefer to do at least 1/3 of the small bowel for biliopancreatic limb. But sometimes, especially when the weight of the patients is high and BMI is even more than 50, risk of although I didn't have in my cases injury to a small bowel during measuring the all length of the small bowel. But in my opinion, the time of bariatric surgery should be as less as possible. And mostly, in my opinion, I tell to my fellowship the time of your operations should be less than 1 hour to decrease significantly your complications. And every time we have time of operations more than 2 or 3 hours, we see the complication rate will increase significantly. So if I see there is risk for measuring the total length of a small bowel, so I prefer to do for her or him mm, mm, the previous BMI as a major determinant uh, mm, for my decision for length of biliopancreatic limb.
Sir, excellent. Sir, regarding this malnutrition or this deficiency of nutrients after MGB or OAGB, especially malnutrition, so have you revised any patient due to malnutrition or weight loss, very weight loss, and what you did?
Yes, I think between my 3,000 cases of OAGB, I've done less than 100 cases revision to for gastrostomy. I've used gastrostomy not only for malnutrition, but also in some cases of uh, bile gastritis and afferent loop syndrome. When we do gastrostomy, but I should do as a research, but as a few cases and as a case report, I should tell you that it will be a good option for afferent loop syndrome, because when the high amount of liquid comes to stomach, if there is a reservoir for such liquid, when we connect the pouch to the remnant of stomach, the bile and pancreatic juice will go to the other side and to the remnant of the stomach, and the patient symptoms from afferent loop syndrome will be disappeared. And I don't have exact statistics about rate of revision for malnutrition, but I think it was less than 100, I think between 70 to about 100 cases of gastrostomy for my patients after OAGB.
Sir, sir, another, so regarding this question, so because now you have started this OAGB since 9 years, so as you have mentioned earlier, at earlier stages, so there was no difference, and for all patients, this BP limb was about 200. So due to this, there was more chance of malnutrition. So when you have standardized your technique now about 3 year or 4 year or 5 years ago, and now this BP limb is not for every patient. So this is the standardized, yes, for different patient, for age, BMI. So after this, when you have standardized this technique, still you are facing malnutrition.
No, fortunately, I should tell you that during these recent years, in my recent patients, I didn't see any cases of malnutrition. Although we can see in some of our cases, in a very, very few cases, after bariatric surgery, even after sleep, we may have malnutrition because of patients, mostly psychiatric problems. But if you rule out the psychiatric problems, that they are very, very, very rare and can be seen in all types of bariatric surgery. I should tell you that after correcting these biliopancreatic limb length, I didn't have seen malnutrition in my patients, and it's a very good operations. And when we did 2-meter length of biliopancreatic limb, our patients have good weight, and most of them had BMI between 25 to 28, 29. But the patient was ill, and he didn't look healthy. But when I corrected the length of biliopancreatic limb, they are seeming very healthy, and it's very important. And I recommend strongly that no one should use 2-meter. And I also write a letter to the writer of the textbook of ASMBS, the chapter about OAGB, which recommended till 2.5 meter for biliopancreatic limb, and I discussed with him about my experiences. And we should know that if we use more length, there will be a high risk of malnutrition and even death of our patients in a few cases.
Sir, excellent. Sir, regarding this GERD after sleeve gastrectomy, so this is also another issue. So, have you experienced to change such a case, intractable GERD after sleeve gastrectomy, and you have changed to OAGB, and what was the result?
Yes, every time when I have, as I told you, the best results after a sleep for weight regain is OAGB. And although they major results for revision was weight regain, but nearly most of them, I don't know how many percent I should do research, but most of them have reflux at the same time, and their reflux will be resolved with OAGB. And but if the patients with previous sleep comes especially for reflux, we prefer to do for patients who come especially for reflux after sleep, we do for them runway gastric bypass.
You prefer Roux-en-Y gastric bypass in such a
Yes.
case.
I think about the different BMI, because I prefer to do OAGB for diabetic patients, and I've done one cases even for BMI less than 25 for diabetes, and 9 cases for BMI between 25 and 30, and other cases were for BMI more than 30 for diabetes. And I've done 9 cases of BMI more than 70 for this BMI. About my intraoperative complication, I have, can I tell my
Yeah,
statistics?
yeah, sir. Yeah, yeah,
Because the
please.
time is over.
Yeah, yeah, sir. Please, please. Yes.
About the intraoperative complications, I have 1.5% of intraoperative complication among my OAGB. 14 cases was mm, bleeding, uh, 2 cases major vessel injury, 3 cases of liver injury, 14 cases of splenic injury, 11 cases of gastrointestinal perforation, and we didn't have any death during the operation. Uh, or about the uh, and mortality, uh, the early mortality, which I mean the first 30 days of post-operation, we had 9 cases of mortality. It means about 0.1% of mortality we had. Um, Pardon, among all the patients, but in many, I had only 3 of 3,000 cases we had died during the first 30 days. It means 0.09, less than 0.1%. We had mortality in 30 days after operation, and our excess weight loss was the highest percentage of the excess weight loss among my patients was in OAGB, and the maximum weight loss was after 1.5 year, and it was 83% excess weight loss. And about comorbidity resolution, I tell you about the hypertension resolution. We had 64 complete resolution and partial resolution or improvement in 27% of our patients. It means it's a very good and effective procedure for hypertension. And for diabetes, I should tell you, type 2 diabetes resolution was about the
Sir, overall, yeah, yeah, overall excellent. Yes.
the data doesn't coming up, and I will tell you what about impaired fasting glucose in 2 years. 67% will be completely resolved, and 20 about more than 90% will be resolved
Diabetes.
about impaired fasting glucose.
Excellent, excellent, sir. Sir, regarding this, so this is I know. So yes, your data and also how you follow your patient. It's amazing, and also it will be a great, I think, data for the world, for the globe, and in future, so many people can also use this data, and that is the exact data from your side. Sir, any bitter experience after MGB or OAGB that still disturb you?
Pardon, I had a call and I didn't have your voice in a few seconds.
Sir,
May
yeah, yes, sure, sure. Sir, any bitter experience after MGB or OAGB that disturb you always? So yes, this was patient like this and that, and you think about that specific patient.
I didn't understand your question completely.
So any complications, sir? Any complication after MGB? Okay, yes, you have mentioned here. So there were some cases that major vessel trauma, because I know you are because there are many fellows in your center, and I remember these cases, and also this trauma or this injury, major vessel injury, was by some fellows. But overall, what is my question regarding any bitter, any experience that was not good experience after MGB that always disturb you?
I think at no, I don't have any bad experience. We have some cases of, as you mentioned, uh, 4 cases of major vessel for first through car entry to IVC and aorta, and that only one cases that by our fellowship before the professor be ready in the operating room, the fellowship did it by himself and he was alone, and unfortunately the patient died. Other patients, fortunately we have 3 other cases of aortic and 2 cases of IVC injury that were completely cured and no problem. But it was not for OAGB. It was the first TrueCar for all the patients, these more than 6,000 cases, and not for OAGB. About OAGB, I have only bad experience with malnutrition, severe malnutrition in my first few cases, only few cases. And fortunately, there were I can tell you, the patients who have died from malnutrition by OAGB, I can tell you only 2 cases I had among my 3,000 cases who died from severe malnutrition.
Sir, excellent, sir. Because now regarding this malnutrition, because the interview, what is our target? Our main target of this interview to share experience of legends. So last week I had Mohit Bhandari, and also I have discussed regarding this malnutrition. What he mentioned. So what they are doing in such a case, because if there is malnutrition, just they do a feeding gastrostomy tube in remnant, like we do in jejunostomy, in feeding jejunostomy. So no, just feeding gastrostomy in remnant, and then they feed the patient with that, just, and also patient. So because in such a case, when there is severe malnutrition, and if we go for another surgery, yes, we can go, but just this is such a resuscitation in such a case when there is very low albumin, and patient is just now patient is very malnutrition, so there is maybe other complication after surgery. In such a situation, they are doing just this feeding gastrostomy tube, feed the patient, and then patient resuscitate, and then they go ahead for further surgery. Sir, regarding this post-op feeding protocol after MGB or OAGB, what is your feeding protocol?
Our feeding protocol is about 10 days liquid diet uh, with 4 liter of liquid. It means 2 liter water and 2 liter uh, uh, mm, milk, yogurt, and mm,
Buttermilk.
also
Yes, sir. You also prefer buttermilk.
and also the soup, the liquid of the soup. Um, we tell آب soup, آب گوشت.
Yeah.
Uh, juice of meat and is it juice or
Yeah. Broth. Yes. Yeah.
broth? Yes. Uh, for 2 weeks, and after that we use mixed soup, the white part of egg and add a it's what
Sir, I cannot hear you. Sir, I cannot hear you. Sir, I think there is a network issue. Okay, it was really a great and very informative interview with Professor Pazouki. So I think, unfortunately, we lose connection. Sir, yes.
yes,
Sir, I think there was a network issue. Sir, last question. What is any message for youngsters who are now new and also they are going to start OAGB? Any message for youngsters?
I think the young surgeons should start with sleep, but every time under the supervision of a experienced surgeon, and they should know that the bariatric surgery is a multidisciplinary approach, and they should have a good team, nutritionist, a psychiatrist, and also a sport medicine uh, to complete the team and help the patient. And I think the best way for young surgeon is to participate in academic fellowship program to have a good experience and have a good results for their patients.
Sir, really appreciable, and this is great honor for me that now
Thank you
I
very
am with my mentor, with my teacher, with my spiritual
much.
father, and now at any stage if we are, so this is all due to you. And from here, I kiss your hands and really respect you. So
Thank you very
it's
much.
really, sir. Thanks, sir, and it was great honor. And my viewers, this was very informative, and I think there were a lot of key points that Professor highlighted in his interview, and hope this interview will be very fruitful. For you must, we will continue our series, and next week we will be with another legend, Professor Osama from Egypt. He is a well-known bariatric surgeon and with lot of experience in anastomosis, gastric bypass. And next week we will be with Osama, and Osama will share his experience. So I will not take your time, sir. Again, so much thanks, and inshallah, see you soon. Also, because after COVID now, COVID era, so we are online. Soon I will see you, and also I will take lot of experience from your side. Thank you, sir.
Thank you. Good night.
Thanks a lot. Good night, sir.
خدا
خداحافظ شما سر.
خداحافظ.